Finals SAQ45 blood transfusion. A 57-year-old patient is scheduled for resection of a colonic carcinoma in 3 weeks' time. The haemoglobin is 10.1 grams per deciliter at the time of referral to the pre-assessment clinic. A. What intraoperative methods can be used to minimize allogeneic blood transfusion? Surgical strategies include senior surgical team, minimally invasive surgery, staged surgery, meticulous hemostasis with diathermy, ultrasonic or laser scalpels, local vasoconstriction, biological hemostats such as cellulose and thistle, cell salvage with leukocyte depletion filter in view of malignancy. In other types of surgery, the use of a tourniquet and positioning to help avoid venous stasis will help minimize blood loss. Anesthetic strategies includes involving senior anesthetic team, regional anesthesia, autologous transfusion, acute normal volumic hemodilution, avoiding venous congestion with adequate muscle relaxation, avoidance of high intrathoracic pressures, avoiding hypercapnia, careful patient positioning, and avoiding venous compression, avoiding coagulopathy by patient warming, avoiding acidemia and hypocalcemia, and near patient monitoring of coagulation. Keeping blood pressure low, this depends on comorbidities. Pharmacological methods includes recombinant clotting factors 8, 9, and 7A, antifibrinolytics such as tranexamic acid, and desmopressin, which promotes von Willebrand factor and factor 8 release from endothelial cells, which improves platelet function. Use desmopressin with caution in decompensated cardiac failure and hyponatremia due to antidiuresis. Procedure-specific techniques such as venodilation in liver surgery, TIVA in ENT surgeries, and avoidance of jugular venous obstruction in neurosurgery. Flow monitoring, optimize tissue oxygen delivery by appropriate fluid and vasopressor use. Blood sampling, avoid if necessary, sample minimum blood volume for tests that are required. Return excess sample blood to the patient. Optimizing physiological tolerance to anemia, increase DO2 by increasing FiO2, reducing PaCO2, and increasing cardiac output by fluids, vasopressors, or inotropes. Reduce VO2 by treating pain and infection, hypothermia, sedation, paralysis, and mechanical ventilation. B. What steps constitute the final check required by the National Patient Safety Agency's Right Patient, Right Blood guideline? At the patient's bedside, the person responsible for transfusion must ask the patient to state name, surname, and date of birth, if able. Check those details against identity wristband. Check those details against the label or tag on the blood unit. C. What are the additional preoperative preparations that must be made if this patient is a Jehovah Witness? Advanced decision. Full discussion with patient regarding what, if any, blood components are acceptable in the absence of family, with time for the patient to make decisions. Meet the patient as early as possible to maximize available time for communication, optimization, and planning. Most Jehovah Witnesses refuse receipt of primary blood components such as whole blood, including autologous preoperative donation, packed red cells, platelets, white cells, and FFP. Acceptance of blood fractions such as cryoprecipitate, clotting factor concentrates, albumin, and immunoglobulin is variable. Check acceptability of cell salvage. So long as lines are primed with non-blood fluids, intraoperative cell salvage is often acceptable. SRA-pheresis, hemodialysis, CPB, and normal volumic hemodilution. Discuss about increased risk of morbidity and mortality if blood transfusion is refused. Emphasize that there are no true blood alternatives. Informing the patient that they are free to change their mind until they are unable to do so due to anesthesia, and that no one else is able to change the directive on their behalf. Can have another conversation in the presence of family or member of the hospital liaison team if desired. Patient consent must be free from coercion. Multidisciplinary input produces a comprehensive management strategy. Proper documentation of all meetings, discussion, correspondence, consents, and advance directives. Improving red cell mass by investigating anemia, iron, B12, and folate replacement. Consider erythropoietin. The effect of these are likely to be limited by the existence of malignancy and short preparation time available. Reducing blood loss. Identify history of bleeding and treat the treatable. Withhold anticoagulants and antiplatelets. Plan for intraoperative care to ensure that senior teams who are willing to comply with the patient's refusal of blood products and cell salvage are all available on the day of surgery. Tranexamic acid, desmopressin, cell salvage, autologous transfusion may all be considered. Reduce phlebotomy. Optimizing physiological tolerance to anemia. This has been discussed in the previous section. Plan for post-op care and discuss rationale with the patient. High dependency post-op care, possibility ventilation on ICU depending on blood loss. Anticipate requirement for critical care, monitoring and resources required for expedient intervention for hemorrhagic complications. Ensure thorough handover, including the wishes of the patient. Consider hyperbaric oxygen facilities if available. Additional information. The goal of transfusion is to efficiently correct tissue hypoperfusion, coagulopathy, or anemic hypoxemia, while minimizing the risk of transfusion-related adverse outcomes. Blood products. Packed red cells is centrifuged from single donor whole blood. Hematocrit is 50 to 70% suspended in SAGM. Volume is 300 ml per unit. Storage at 2 to 6 degrees Celsius. Shelf life 35 days. A dose of 4 ml per kg will increase HB by 10 grams per liter. Derivation of platelets is from pooled Buffy coat from centrifugation from 4 to 6 whole blood donations or by apheresis from a single donor. Composition is 240 times 10 to the power of 9 platelets. Volume of 1 unit is 300 ml. Stored at 20 to 24 degrees Celsius on an agitator. Shelf life is 7 days. 1 unit will increase platelet count by 20 to 40 times 10 to the power of 9 per liter. FFP is obtained from apheresis donation from a male donor. It is rapidly frozen within 8 hours of donation. Composition is 0.5 grams of fibrinogen. Factor 7, more than 0.7 international unit per mil, and labile factors. Volume is 300 ml. Storage is at negative 30 degrees Celsius. Shelf life is 2 years if frozen, 4 hours if thawed. Dose is 10 to 15 ml per kg. Cryoprecipitate is derived from controlled thawing of single donor FFP, pooled from 4 to 6 donors. Contents includes 2 grams of fibrinogen, von Willebrand factor, factor 8, 13, and 7, and fibronectin. Pooled volume is 100 to 200 ml, stored at negative 30 degrees Celsius. Shelf life is 2 years if frozen, 4 hours if thawed. 1 unit per 30 kg body weight to increase plasma fibrinogen by 1 gram per liter. Transfusion triggers. Considerations includes clinical judgment, lab results, point of care test, best available evidence, timing, dose and rate of administration, risk, benefits and available alternatives to transfusion. Red cell transfusion policies have become increasingly restrictive in response to emerging evidence of harm associated with unnecessary transfusion. HB level of less than 70 grams per liter is the transfusion threshold for clinically stable ICU patients. HB level of less than 80 grams per liter. Red cell transfusion is indicated in patients with acute coronary syndrome, hip fractures, or CVS disease. At a HB level of 70 to 100 grams per liter, RBC transfusion is indicated in intraoperative major blood loss or evidence of hypoxemia. When HB is more than 90 grams per liter, transfusion is usually inappropriate. Exceptions include impaired tissue oxygen delivery, such as cerebral ischemia. Indications for cryoprecipitate transfusion includes massive transfusion, aim for fibrinogen level of more than 1.5 grams per liter, obstetric hemorrhage, and DIVC, aim for fibrinogen level of more than 1 gram per liter. Functional fibrinogen assays may guide cryoprecipitate transfusion more accurately than absolute levels of fibrinogen. Platelet transfusion triggers. At a platelet count of less than 10, transfusion is indicated as risk of spontaneous hemorrhage. At a platelet count of less than 20, Transfusion is indicated in the presence of risk factors of hemorrhage or in critically ill patients. At a platelet count of less than 50, transfusion is indicated for most invasive surgery. AOA now recommends platelet count to be more than 50 for performance of regional blocks. At a platelet count of less than 75, transfusion is indicated in massive hemorrhage in order to consistently maintain platelet count at more than 50. At a platelet count of less than 100, transfusion is indicated for high-risk closed compartment surgeries such as ocular and neurosurgery. The units for the above-mentioned platelet counts are in 10 to the power of 9 per liter. Other indications for platelet transfusions includes pharmacological platelet inhibition or inherited disorders of platelet function. Contraindications for platelet transfusion includes TTP, HUS, HIT, and ITP. FFP transfusion indication includes coagulation factor or protein deficiencies only if specific factors are unavailable. Example of protein deficiency is for treatment of pseudocholinesterase deficiency. FFP is indicated in massive transfusion. It is administered empirically as 1:1 ratio with RBCs or 15 ml per kg per blood volume. Maintain INR less than 1.5. FFP is used for warfarin reversal when prothrombin complex is inappropriate or unavailable. FFP is used in TTP for plasma exchange. FFP is used in DIC when DIC is associated with bleeding. Maintain INR less than 1.5. Initial dose is 15 ml per kg. FFP should not be given for prolonged PT or INR in the absence of bleeding. Other derived products. Fibrinogen concentrate. This is a freeze-dried powder containing 1 gram of purified human fibrinogen. It is reconstituted, and when administered, it raises the patient's fibrinogen by 0.25 grams per liter. No thawing or blood type matching is required. It is indicated in hypofibrinogenemia, cardiac surgery, obstetric, bleeding, and major trauma. Recombinant factor 7A or Novo7 is a freeze-dried powder. It acts at the tissue factor 7A complex at the site of endothelial damage. Effects appear to be localized to the area where the vessel is damaged, leading to few systemic side effects. Indications include congenital factor 7 deficiency and bleeding in hemophilia A or B in the presence of inhibitors to factors 8 or 9 and in severe uncontrolled bleeding. A Cochrane review in 2012 indicated that the effectiveness of Novo7 as a more general hemostatic drug, either prophylactically or therapeutically, remains unproven. There is increased risk of arterial events in patients receiving Novo7. The use of Novo7 outside its current license indications should be restricted to clinical trials. Prothrombin complex concentrate. This is a sterile freeze-dried powder. It does not need to be cross-matched or thawed. 3-factor PCC contains factor 2, 9, and 10. 4-factor PCC contains factor 2, 7, 9, and 10. It is indicated to replace congenital factor deficiencies when purified single-factor concentrates are unavailable. It is also used in the reversal of vitamin K antagonists such as warfarin. Pros includes it is quick, it is delivered in small volume and has fast effect. Cons, it is expensive. Individual factor concentrates are available for congenital or acquired factor deficiencies. Immunoglobulin products, such as IgG, are used in immunodeficiencies, immunomodulatory therapy, post-exposure prophylaxis, and hyperimmune therapy. Albumin is obtained from fractionization of whole blood. It has a molecular weight of 69,000 daltons and is indicated for hypovolemia, hypoalbuminemia, priming fluid in CPB, and as a replacement solution in plasma exchange. Post-hoc analysis of the SAFE trial showed that there is increased mortality when albumin was used rather than normal saline in the resuscitation of critically ill patients with traumatic brain injury. Albumin has not shown to improve survival in either all-corner admissions to intensive care or in the treatment of severe sepsis. Safe transfusion practices, informed consent, confirm patient identity, check unit to be transfused, inspect the bag for integrity, discoloration, and clumping, use a 200 micron integral screen filter, replaced if clogged. Time limits for transfusions: packed red cell less than 4 hours, platelet less than 1 hour, FFP less than 4 hours, cryoprecipitate less than 4 hours. Blood warmers are not required for routine transfusion, but is indicated in massive transfusion, neonatal exchange transfusion, rewarming during CPB, and transfusions for patients with clinically significant cold reactive antibodies. Do not warm blood products beyond 41 degrees Celsius. Fit with visible thermometers and audible alarms to avoid hemolysis. Monitor for adverse events. Common adverse events include febrile non-hemolytic transfusion reactions, minor allergies, hypotension, transfusion-associated circulatory overload, hypothermia, and immunosuppression. Rare transfusion adverse events include acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction, sepsis, anaphylaxis, viral infection, post-transfusion purpura, TRALI, and transfusion-associated graft versus host disease. Single-unit transfusion is recommended in stable non-bleeding, normal volemic patients. Transfusions should be conducted 1 unit at a time. Proper documentation, as 100% traceability of transfused blood is a legal requirement. Compatibility testing. In group and screen, a patient's blood sample is tested to determine ABO and RhD antigen type and to detect red cell antibodies. In compatibility testing, this involves either a serological cross-match to ensure compatibility or an electronic cross-match on the basis of antibody screen. This table shows the ABO compatibility of blood components and recipients. If the recipient is blood type O, compatible donor for red cells is blood type O, for platelets is O or A, for FFP or cryoprecipitate it is O, A, B or AB. If the recipient is blood type A, compatible donor for red cell is A or O, for platelets A or O, for FFP or cryoprecipitate A or AB. If the recipient is blood type B, compatible donor for red cells includes B and O, for platelets B or O, for FFP or cryoprecipitate B or AB type. If the recipient is blood type AB, compatible donor for red cell transfusion is AB, A, B or O. It is the same with platelets. For FFP or cryoprecipitate, it is AB type. If the recipient blood type is unknown, compatible donor for red cell transfusion and platelets is blood type O. For FFP and cryoprecipitate, it is blood type AB. Platelets weakly express ABO antigens. Non-ABO compatible units of platelets can be used in the event of life-threatening hemorrhage, but these platelets will have a reduced lifespan in vivo. Cryoprecipitate and FFP contain anti-B or anti-A IgM antibodies, depending on the donor blood group. They must not contain IgM antibodies against antigens expressed on recipient cells to be compatible. Group-specific blood can be issued significantly quicker than fully grouped and screened blood, 15 minutes versus 45 minutes. Group-specific blood is an alternative to using O-negative blood when transfusion is required urgently, but not immediately. The Bombay HH blood group is a rare blood group. Phenotypes of this blood group lacks the H antigen on the red cell membrane and have anti-H in the serum. They fail to express any A, B or H antigen on their red cells or other tissues. The only blood type that is compatible for transfusion is the Bombay blood group. For Rhd compatibility, IgG antibodies against the Rhd antigen, also known as anti-D, is only formed as a result of allogeneic exposure. Rhd antigens are expressed on RBCs. They are not expressed in platelets, but residual red cells in platelet units may sensitize Rhd negative patients. Residual red cell fragments in cryoprecipitates and FFP are much less immunogenic, hence any Rhd types can be safely given. Positive antibody screens. Patients with positive antibody screens may require specific antigen-negative blood components. However, not all antibodies detected are of clinical significance. Patient blood management, the 3 pillars, includes improving red cell mass, reducing blood loss, and optimizing physiological tolerance to anemia. Strategies to improve red cell mass includes investigating anemia, iron, B12, and folate replacement, and consideration of EPO. Strategies to reduce blood loss: identify history of bleeding and treat the treatable, withhold anticoagulant and antiplatelet, proper surgical and anesthetic technique which has been discussed earlier, consideration of tranexamic acid, desmopressin, autologous transfusion and reduced blood taking, and red cell salvage. Consider red cell salvage for all patients where there is more than 500 mL or more than 10% of total blood volume loss being predicted. Autologous whole blood is collected via suction tubing into a reservoir during surgery using a filter. The blood is anticoagulated with citrate or heparin. It is centrifuged to isolate red cells and washed with 1 to 2 liters of normal saline before being resuspended and reinfused. The machine produces packed red cells suspended in normal saline with a hematocrit of 50 to 60% without coagulation factors or platelets. It can provide the equivalent of 10 units of bank blood per hour. Absolute contraindications includes aspiration of substances that must not be given IV, such as chlorhexidine and fibrin glues. Relative contraindications includes collection of blood containing septic material, malignant cells, and amniotic fluid. Leukodepletion filters reduces the risk associated with salvaged blood in cancer surgery or from an infected surgical field. Allogeneic blood transfusion may worsen outcomes, possibly by immunomodulation. Hence, some cancer centers advocate cell salvage to avoid this. In caesarean section, the Salvo trial in 2017 did not record any amniotic fluid embolism following routine use of cell salvage, but did not demonstrate any reduction in allogenic transfusion. Cell salvage during caesarean section should be considered only where there is high risk of obstetric hemorrhage. Strategies to optimize physiological tolerance to anemia includes increasing delivery of oxygen and reducing oxygen consumption. DO2 can be increased by increasing FiO2, hyperventilation, increasing cardiac output, and hyperbaric oxygen. VO2 can be decreased by treating pain and infection, avoiding sympathetic activation, avoiding hypothermia, sedation, paralysis, and mechanical ventilation. Massive transfusion. This is defined as 5 units or more packed red blood cells transfused in less than 4 hours, or more than 10 units of packed red cells administered to a patient within 24 hours. The goal is to expand circulating volume rapidly, economically, without adverse effects. Rapid, large volume hemorrhage leads to the triad of death, which includes acidosis, hypothermia, and coagulopathy, each individually causing worsening of the other two. Acidosis is due to systemic hypoperfusion following rapid, large volume hemorrhage, leading to reduced DO2 and anaerobic metabolism and lactate production. Acidosis results in reduced myocardial contractility, brady or dysarrhythmias, vasodilation, reduced SVR and hypotension, and reduced activity of clotting factors and platelets. Hypothermia is due to administration of cold IV fluids and exposure of the patient, for example, for vascular access and resuscitation. Effects are similar in acidosis. Coagulopathy is due to hypoperfusion, which activates the protein C pathway, deactivates factor 5A and 8A, and initiating fibrinolysis and coagulopathy, and consumption of clotting factors. Coagulopathy leads to DIVC and bleeding. Resuscitation priorities during massive hemorrhage and transfusion. Ensure adequate staffing and assistance. Maintain circulating volume. Request additional equipment. Prevent and treat hypothermia, coagulopathy, acidosis, and sequelae of massive transfusion. Ensure senior surgical and anesthetic help is adequate. Nominate a crisis leader. Manage and assign roles to staff. Notify blood bank. Declare the need for massive transfusion. Have a dedicated runner to obtain blood products. Dedicated staff to check and administer blood products, and staff to set up key equipment. Maintain circulating volume by rapid source control, immediate request of 3 units of packed red cells, O negative blood if cross-matched blood is not immediately available, large IV access, give crystalloids until blood arrives, provide FiO2 100%, and reduce dose of anesthetic agent, request additional equipment such as rapid infusion device such as level 1 or Belmont, and cell salvage. Hypothermia can be treated with forced air warming, increasing ambient temperatures and fluid warmers. Coagulopathy can be treated with administering blood components such as plasma and platelets, treating hypothermia, close monitoring with POCT, ABG, FBC, coag profile, and electrolytes every 30 minutes. Consider tranexamic acid, Novo 7, and discussion with hematologists in non-surgical uncontrolled bleeding, anticoagulated patients, and patients with inherited bleeding disorders. Acidosis can be treated with increasing DO2, increasing minute ventilation, and treating hypothermia. Treat hyperkalemia and hypocalcemia, which is common in massive transfusion. Treatment goals: MAP more than 50 mmHg. Do not normalize MAP until surgical source control. Aim MAP more than 70 mmHg if head injury to provide adequate cerebral perfusion pressure. HP should be more than 70 grams per liter. Fibrinogen should be more than 1.5 grams per liter for non-pregnant and more than 2 grams per liter for pregnant patients. Platelets should be more than 75. Ionized calcium should be more than 1 millimole per liter. pH should be 7.35 to 7.45. PT-APTT ratio should be less than 1.5 times the upper limit of normal. Ensure normothermia. Ethical and legal considerations with Jehovah Witnesses. Competent patients. Competent patients have the right to autonomously decline transfusion. For this to be informed consent, an anesthetist is obliged to inform patient of the risk, benefits, and alternatives to their decision, including probable outcomes of doing nothing. Clinicians must also be satisfied that the patient's decision is free from coercion, which may require consenting a patient individually, away from family or associates. Administration of blood products to a competent patient who has refused blood transfusion is unlawful and may lead to professional and criminal proceedings against the doctor. Advance directives. Advance directives state a patient's acceptance or otherwise of a specific medical intervention for situations in which they would be unable to provide consent. They must contain clear and medically interpretable instructions about the treatments, which are acceptable or unacceptable. They must also be clear that these directives are to apply even if a patient's life is at risk. Advance directives may be issued by a church. However, these often lack sufficient medical detail. Many hospitals will therefore have checklist-style forms to clearly document a patient's consent. In emergency surgery, for conscious and competent patients, they must be provided the opportunity for informed consent and have their wishes regarding blood transfusion acceptance or refusal respected. For unconscious or incompetent patients, this presents with uncertainty. In emergency situations where the patient wishes are unknown, doctors must act in the best interest of the incompetent patient, which may include providing blood transfusion. Opinions of relatives or associates that the patient would not accept a blood transfusion are insufficient. Advance directives should be sought and verified. If the proposed treatment is included in a verified advance directive, the patient's wishes must be respected, unless there is evidence that the directive no longer represents the patient's wishes. Inclusion of senior departmental and legal support staff is advisable. Children of Jehovah Witnesses may present particular difficulty. If parents refuse permission for blood transfusion, it may be necessary to apply for a legal guardianship in order to administer a blood transfusion. In an emergency situation when the child of a Jehovah Witness is likely to die without blood transfusion, blood should be given. Courts are likely to uphold this medical decision. Thank you.